Okay, I think we'll make a start. So I'll start by saying croeso, welcome everybody, and thank you for joining us at this Cognition and Mental Health webinar hosted by the National Centre for Mental Health, or NCMH as we like to call it. I'm Julia, I'm the Communications Officer here at NCMH, and I'm joined by mental health and cognition researcher, Dr. Amy Linham, as well as NCMH Partnership and Research member, Tony Cope. So today we'll be discussing the impact of mental health challenges on cognition and how digital cognitive assessments can support both research and clinical care. So without further ado, I'll just hand you over to Amy. Thanks, Amy.
Brilliant. So I'm just gonna click share a minute. Great, fab. Okay, hi everyone. Thank you for joining us, particularly on such a lovely sunny evening. I really appreciate you coming in from the sunshine, or maybe you're out in the sunshine enjoying it, in which case, lucky you. So my name's Amy Linham. I'm a research fellow within the National Centre for Mental Health. And today I'm going to be giving you a bit of a whistle-stop tour, really, of some of the work that we've been doing looking at mental health and cognition. So this is going to be quite a broad overview. I'm not going to go into a huge amount of detail given the time that we've got. So if you do have any questions, then do please pop them into the Q&A. And we'll do our best to answer as many of them as we can. And thank you to everyone as well who's already submitted questions for us. We've had some really, really interesting questions submitted. Okay, so let's start off by just talking about what cognition is. So cognition are the thinking skills that people use in their everyday lives. So this includes things like memory, concentration, problem solving, learning and planning, as well as skills that help us socialize. So things like emotion recognition. And this is important because we know that cognition is associated with both our mental and physical health. And also cognitive impairments have been linked to early risk of mortality and have predicted daily difficulties and disability, particularly in people who've experienced mental health problems. Importantly, for people with existing mental health problems, there are a few treatment options available for impaired cognition. So this is really an area of unmet need clinically. So just to give a broad introduction, how do we actually measure cognition? So to measure it, we'll typically ask participants to complete a series of tasks. So these are like games or puzzles, and I've put a sort of example on the side here. On the right, so this is a pattern matching task. So basically what you have to do is you're given these sort of three different pictures and you need to pick the picture that matches that pattern. And this is an example of problem solving skills. And as you go through this task, the examples get more and more difficult. And then, so how do we then identify whether someone is experiencing cognitive impairment? Well, there's kind of two ways that we can do this. So one is we can compare performance from people with mental health problems to people without a history of mental health problems. The other way that we can do it is we can look at a sample of the general population who've completed the same task as you, and then we can look at where people sit within this general population. And so if people sit towards the bottom of a particular population, that might indicate that someone has some cognitive problems. So mental health affects cognition in a very broad sense. So this is a paper, a clinical review that was done by Abramovich et al. In 2021. And what they looked at was a broad range of different psychiatric diagnoses, as well as a range of different cognitive abilities. And they basically mapped out the associations between each of these diagnoses and the different cognitive abilities. And so in this very complicated looking diagram, what you can basically see is every single one of these lines represents that people on average with these diagnoses had lower performance than the general population. And if there was a large difference, then I've mapped it out in green. If there's a medium difference, we've mapped it out in orange, and small effect is in pink. And so what you can kind of generally see from looking at this is that most of the mental health problems that they looked at were associated with poorer performance across a whole range of different cognitive abilities. It's not the case that one particular psychiatric diagnosis was associated with one particular cognitive ability. Broadly speaking, any kind of mental health problem seems to have the potential to affect your cognitive abilities. But there are some patterns that emerge from this. So you can see, for example, if you look at schizophrenia, which is the third one from the bottom, you can see there's mostly green lines there. And what this tells us is that the largest effects are really seen in people who experience schizophrenia. And we know this through decades of research, that people with schizophrenia have the highest risk for quite profound cognitive impairments. Whereas in other disorders, these are perhaps lesser. So, for example, in mood disorders like bipolar disorder and depression, as well as disorders of addiction, we see kind of these medium to large effects. And then there's kind of smaller effects for kind of anxiety disorders. But key to this is that this is on average. So not everyone with schizophrenia will necessarily experience cognitive impairment. And not everyone with, for example, an anxiety disorder won't experience a cognitive impairment. They could experience a severe cognitive impairment. So there are these individual differences. So within the National Centre for Mental Health, we were really interested in looking at kind of mapping out these kind of cognitive profiles across different diagnoses. And one of the fantastic things about the centre is that we have data on a whole range of people who've experienced completely diverse different mental health problems. So we can really look at this. So what we did was we took 554 people with a history of any kind of mental health problem who'd completed these 9 tasks. So these tasks measure a range of different abilities. They include attention, verbal memory, visual memory, working memory, emotion identification, all these kind of different abilities. And then we also had 143 people who'd never experienced any kind of mental health problem. And we did something called a cluster analysis, which is a data-driven approach that allows us to group people who have similar cognitive profiles. So we looked at people's performance on these tasks, and then we grouped them according to whether they were similar. And we looked at no other information. It was purely based on their cognitive performance. We weren't looking at whether they had a particular diagnosis or symptoms. And from this, we identified 3 clusters. So on this graph here, you can see we've got the controls on the left, and then we've got a group of people that have relatively preserved cognitive function, and in some cases, they're doing quite a bit better than the controls. We have a group of people after that who have kind of globally impaired. So they have lower performance on every task that we measured compared to controls. And then finally, we have this group of people that we sort of labeled as kind of partially impaired. So for some tasks, they were performing below controls. So things like on the verbal memory task, on the attention task, on the emotion identification task. But on other tasks, they were actually performing within the same range as controls. So that included things like the a task of problem solving and a task of visual memory. And so what we're interested in looking at is, does someone's diagnosis actually predict whether they're in one of these clusters? Or is it the case that, you know, across these clusters, it incorporates all different diagnoses? And so what we found was that if you look at this graph here, each one of these dots represents an individual. And the color of that dot tells you what group they were put into. So, and what you can see, I've put the top 5 diagnoses that people reported receiving from a doctor, and then we've kind of grouped some of the remaining ones as other mental health diagnoses at the bottom. But what you can see is that every diagnosis was represented in every cluster. So even though we know that on average people with psychosis have the worst sort of cognitive function of all the kind of diagnoses that we look at, there were still people in that group that had what could be categorized as preserved cognition. And likewise, the opposite was true. So there were people, for example, in the anxiety group who could be considered sort of globally impaired. So they had more severe cognitive problems. But generally, we also saw that there were 3 diagnoses that would really predict your cluster membership. So people with psychosis were most likely to end up in the globally impaired cluster. People with depression and anxiety were least likely to end up in the globally impaired cluster. And then participants with depression were most likely to end up in the partially impaired cluster. But the take home from this is that there are these kind of individual differences. It's not, when we're looking at cognition, we're quite often looking at averages across a particular group or people with a particular diagnosis, but it's not necessarily the case that everyone in that group experiences these problems. However, for those people who do experience cognitive problems, these can have a profound impact on their daily life. And so we looked at this in 2 separate samples. We looked in the National Centre for Mental Health, so this was the sample that I just showed you, as well as Healthwise Wales, which is a population sample of people. It's around 4,000 people from Wales that have completed our cognitive assessments. And these are people who sort of represent the kind of general population of Wales. So some of them will have experienced mental health problems and some won't. And what we found was that people with lower cognitive performance, or people who were sort of experiencing cognitive impairments, were most likely to report difficulties across 6 different areas of life that we measured. And this included mobility. So this is like physical mobility, how far you can walk, how long you can stand. Self-care, so your ability to kind of look after yourself. Household responsibilities. Cognitive problems refers to reported cognitive problems. So this is of the people who sort of that we found had sort of measurable cognitive problems, how many of them were reported that they felt that they were experiencing problems with their memory and concentration. Social life, so relationships, friendships, and finally society participation. So this is things like how involved you get, are you able to get with your local community, for example. And for both our clinical sample and our population sample, we see the same sort of thing. So lower cognition is associated with more difficulties in these areas. And so depression and anxiety were the 2 sort of most commonly reported mental health problems across these 2 samples. So we were particularly interested in whether that was having any particular impact, because we know that depression and anxiety is associated with at least sort of small to moderate changes in your cognition. And we also know that they can have a particular impact on how you're able to function day to day. And so we looked at this in 2 ways. We looked at someone's current symptoms of depression and anxiety. This is regardless of whether you've ever received a diagnosis of depression and anxiety. So we simply measured someone's symptoms on the day that they did the cognitive assessment. And it didn't matter whether or not they'd ever been given a diagnosis. It was just how many sort of symptoms do you have and how severe are they? And then we looked at historical diagnosis. So have you ever been given a diagnosis of depression or anxiety by your doctor? And what we found was that current symptoms of depression and anxiety partially explained this relationship between cognitive function and daily difficulties. So people with lower cognitive performance were more likely to report that they were experiencing higher rates of symptoms of depression and anxiety. And this then partially explained how many sort of daily difficulties they were reporting. In Healthwise Wales, we also found that a historical diagnosis of depression or anxiety partially explained this relationship as well. We didn't find this in NCMH, but I think this is because this is NCMH is a sample of people who've experienced any sort of mental health problem. So you're not just comparing people who have had depression or anxiety with people who have no history. You're comparing them to people who may have schizophrenia or bipolar or PTSD, and so it's sort of, it's not quite like for like. Okay, so just the key kind of take-home messages. So poor mental health can be associated with cognitive problems. This isn't sort of specific to one diagnosis or one area of cognitive ability, although we know overall schizophrenia is associated with the biggest impairments in cognitive function. But we've also shown that it varies between individuals. It's not as simple as if you have a particular diagnosis, that means that you will absolutely experience these cognitive impairments. Lower performance on these cognitive tasks were associated with daily difficulties, and this was across a range of different abilities. So this was things from physical mobility to self-care and your social life. And finally, we found that current symptoms of depression and anxiety may play a role in both the cognitive problems and in the kind of daily difficulties that people are experiencing. So that's all from me for a second. So I'm just going to stop sharing, I hope. It doesn't seem to want to, oh, hang on. Why is it not stopping sharing? Sorry, hopefully it will stop in a minute. So I'm going to pass over to Tony, who is the research partner for the Conquer project, and as Julia mentioned, is also a member of NCMH's Partnership in Research initiative. And he's going to tell you a bit about his experiences and some of the incredible public involvement work that he's done.
Hello.
Hello.
Am I going to be whizzed over into the spotlight? I don't know.
I can see you. You're main on my screen.
That's fine. Okay. Right. So for people who know me, I'm putting myself on a timer. So 15 minutes. Here we go. I'll be yanked off in 15 minutes. So yes, cognition. I've had a real journey with it, and half the time I didn't even know what it was. But my diagnostic journey is that I struggled with for 20 years. Well, going back to the very beginning, my mother had schizophrenia. Father didn't, so I got diluted, and I met them halfway and ended up with bipolar. Go me. So anyway, so that's a genetics I used to wear. So I've had a very interesting journey with the diagnosis. So my first symptoms of I don't think something's quite right were when I was 18. And then it only took 20 years later for me to pluck up the courage to face the fact that something really seriously wasn't right. And I had a marvelous GP who was a locum, and he got me that psychiatrist referral, and the psychiatrist diagnosed me with bipolar depression and anxiety. So like I say, it only took 20 years, but I had 20 years of lots and lots of symptoms. So I had the classic bipolar, the highs and the lows, and then the highs and then the lows. But concentrating on what we're concentrating on this evening, cognition. It really does have a bearing on your cognition. So basically, I did very well at school. I did very well, got my degree. Eventually, that's another story for another evening. And I had a glorious career as a biomedical scientist. and they're culminating in running my own business. Now you ask, like, how on earth can you do that with a mental health diagnosis and your cognition all over the place? Well, you can, especially if you're high functioning, like I am. But see me on a day when my cognition is just shot to pieces, and even I sort of look in the mirror and think, my God, is this the same human being? Well, timeline, you all know that. So it is very, very interesting. So what I found was that when I was having my highs, my cognition and my mental operation was supercharged. I was going to run this planet. When I was depressed, I couldn't even manage to have a shave. My cognition had disappeared. And that's exactly how it is. So cognition is, and this goes for everybody, it's a movable feast, and it isn't something that you should assume is always going to be there, because that's when it disappears. And that's exactly what happened to me. You know, I seriously thought there was nothing wrong with me. I was not going to be like my mother. She was put away in the psychiatric unit for 5 years. I didn't see her between me being 5 and 10. That wasn't going to happen to me. No way. And that's why I resisted having a diagnosis for 20 years, because people like my mother, they get put away. And that's what I thought. That's exactly what my brain was telling me. This is not happening, son. You are not going to be like your mother. But then events overtook, including the death of my mother, which actually precipitated my first breakdown. And I mean, it was serious. Everything just collapsed within months. So when your life disintegrates, you tend to have a breakdown, and that takes your cognition right down the toilet with it. But you find a way of rebuilding it. And that's exactly what I did. So years went by. I ended up running my own business once again. Wow. But then that turned into a nightmare, another breakdown. Recovered from that. I'm quite resilient. People underestimate my resilience, especially my enemies, which is to their detriment. But that's going to be in several books. They're all terrified when those books come out, by the way. And then I had another round of going back to the workplace. It was never going to happen. Once again, I had a third breakdown. And I just thought, I can't keep doing this, because, you know, every time it was taking longer and longer to recover. And I think another aspect of my situation was that as I got older, my ability to keep running away from things reduced. So it is something that, and Amy might have the stats. It's something that sort of is more prominent as people age. That's what happened with me anyway. So anyway, we fast forward to 2022, and obviously everybody's in the pandemic, and I was just coming out of my own personal lockdown, which was depression. But I thought, well, I'm not going back to the workplace, so what am I going to do with the rest of this incarnation? And then I was getting lots and lots of emails from Health and Care Research Wales. Hello, the team's in. And I pressed a few buttons and I joined a few forums and I joined a few online things. And then suddenly I was involved with Amy. So I did, I got involved with the Conquer part one, and that was very interesting. So I was able to contribute and sort of say, well, have you thought about this? Have you thought about that? Have you thought about something else? And it was, you know, they took things on board, and it sort of really was very, very encouraging because as it would be. So I thought, maybe I'm onto something here. Maybe maybe I need to keep this ball rolling. So I did, and lots of organisations across the UK, Europe, and now I'm going global. Either have you know, asked me to join in. I benefited from my experience of, because I've got comorbidities coming out of my ears. So it's not just the mental health anymore. It's type 2 diabetes. I've got long COVID. Thank you to the pandemic, and all of these things do affect your cognition. Type 2 diabetes definitely affects your cognition, and boy, oh boy, does long COVID. You know, I mean, basically, I used to be able to have what I call my bipolar nap in the afternoon, and I'd get a second wind. I have my bipolar long COVID nap, and many times it's just like I'll have something. I'll crawl through the evening, and then I'll go to bed early. So physical health comorbidities definitely do affect mental health, and this needs to be sort of taken on board, and you know, waving the long COVID flag. We, and using the wrong we there, we need far more research into long COVID, because guess what? There's at least 2 million of us affected by it, and we don't feel the love, not anymore. So anyway, that's just my shout out for my long COVID family. But yeah, so going back to the research. So Amy, she knows that she's not my only rodeo in cognition. So I've been involved in the crib study. I'm not going to spoil anything by telling you which arm I was in, but that was another interesting journey with cognition, and they tested cognition with similar tasks to Conquer. So there were games and you know, remember words and remember strings of numbers, that sort of stuff, and also do a job interview in a hotel. Well, I'd worked in a hotel, so that was okay, but it was a very strange interview. But anyway, so yeah, it really is really very interesting, and I've learned so much. So I've learned so much about how my conditions work. I've definitely learned a lot more about what cognition is, and the way that I personally think about cognition. I look at it as it's not intelligence. It's more than that. It's how your brain works. And the secret is everybody's brain works for their own brain. It's an individual thing, but it's like a Lego brick scenario. Different pieces build the house, or in my case, the Death Star. That's another story. So so it's different pieces and you bring them together in your own way. And I would sort of say that cognition encompasses not just the normal intelligence, but emotional intelligence, gut instinct, how you interact with people. So like Aaron was saying, social intelligence. It's all those things and so much more. And I've sort of realized that the way that I do things and the reason why I do things is because of my cognition, and my cognition isn't something that sort of suddenly happened when I started getting involved with Conquer. It's been there since the very beginning. And that's another thing that people need to realize. It's like cognition isn't something special. There's something that you're born with, but your cognition is your cognition, and that's the secret. You know, like, don't compare and contrast your cognition with other people, because other people are other people. You're your own special creation, but you make your cognition work for your piece of the universe, and that is the way to approach it. Because if you do that, then hopefully it will coincide with other people's cognitive universe, and that's how we make the planet better. So it's been an amazing journey. The last 3 years have been amazing, but the last 55 years, yes, I do moisturize, has been an amazing journey too. And with Amy's help and with all my other family's helps, I'm working all over the UK. It's going to only get bigger and better. And with that, I'm handing back to Amy, and guess what? I've got 25 seconds left. Results.
Sorry, Amy, you're on mute at the moment.
Yes, I am. Sorry.
Has to happen once.
I know.
I just can't get a staff.
I'm a Teams newbie. That's what it is. I know. I was saying that, yeah, you did better than me, because I definitely went over my time. So for the next section, we're just going to talk a little bit about the cognitive assessment that we're using in NCMH. So this is a cognitive assessment that was originally developed for research, but we're now expanding to see how it might be useful in clinical settings. So I'm going to talk very, very briefly just about what it is. And I'll also kind of bring Tony in to talk a little bit about how he's been involved. So our cognitive assessment is called the Cardiff Online Cognitive Assessment. It's very original, or CONCA for short. And so this was designed specifically to measure sort of overall cognitive function. So as I kind of mentioned in my first talk, and as Tony is brilliantly described as well, is like generally for a lot of people, they experience this kind of global change in their cognition. It's not any sort of one area. And so what we were really looking to do was create an assessment that would be very brief, but that would really capture how someone was doing. And so we created this set of tasks. Well, we didn't create the tasks. We created this assessment tool using some tasks from our collaborators in Harvard University. And it basically consists of 5 tasks. So 3 of them you can do in 10 minutes, and they'll give you a very good global measure of your cognition. And that's comparable to doing a much longer assessment. And then we have these 2 optional extra tasks, and one of them is to kind of measure the more social aspects of cognition. So that's the morphed emotion identification. And then the matrix reasoning task is a more kind of challenging problem solving task that really kind of gives you a bit more kind of sensitivity for people who perhaps are experiencing some difficulties, but not sort of as globally impaired. And so we developed this as a website, and the reason for that originally was because we were doing genetic research kind of all over the world, and we wanted something that we could kind of easily share out with our collaborators, and that's something that we are definitely doing. But we also wanted something that would be very user friendly and that could potentially be used clinically. And so we developed the website with support from patients and clinicians. And that was alongside funding from the Medical Research Council, Wellcome Trust, and currently we're funded as part of my fellowship, which is from Health and Care Research Wales, or Welsh Government. So there's 5 tasks, as I mentioned, so these are shown here, and just very briefly, these tasks measure things like processing speed, working memory, vocabulary skills, emotional identification, and kind of problem-solving abilities. So this project has been going on for 10 years now, which was a bit horrifying when I realized that when I was making this slide. I hadn't realized it'd been that long. So in 2015, we developed this prototype that was sort of 9 tasks. And then we did an initial sort of validity study looking at whether if you administer tasks online, can people do them? And are they comparable to if you gave someone a standard old school cognitive assessment, which used to be kind of pen and paper, getting people to kind of complete mazes, look at pictures, that kind of thing. In 2017, we then started rolling it out as an assessment tool in the National Centre for Mental Health. Then we collected feedback during that time, and then based on that feedback between 2018 and 2021, we then started reducing the number of tasks down to 5. Firstly, because we wanted something brief, and secondly, because people said it was too long. And we then sort of designed it to be a lot more user-friendly. So the website that I've just shown you is the current version. We were using a bit more of a sort of rudimentary website before, but we really managed to refine it with brilliant support from our public involvement group. At that time, we then started rolling it out to Healthwise Wales, which is the population sample that I mentioned. And then in 2022, Tony's was when you came in, I think.
Yeah, it was late 2022.
Yeah, so in 2022, we were really started to become, we'd kind of had it in our heads for a long time that perhaps this could be a clinical tool. But in 2022, we were able to get some funding from the Wellcome Trust to really realise that and to be able to explore how it could potentially be used. So then we work with some clinicians and with public involvement members, including Tony, and we designed this new interface. And the new interface basically had 2 elements to it. So the first element was a report that we could give to the clinical staff. So you could give this to people in your clinic, and then you would get a report that was easy to interpret and easy for you to understand. Oh, I don't know how that happened. And then the second element was we wanted to be able to give informative feedback for both anyone who sort of take part in this in a clinical setting, but also for our research participants who for years had been saying to us, well, I've done this cognitive assessment, but I don't know how I did. I really want to know how I did. And that is, of course, completely understandable. So we wanted to be able to provide that for people. So I don't know if there's anything you wanted to add there, Tony, just around kind of that time where we were working on this, kind of creating this sort of all these adaptations.
Yeah, I mean, so yeah, so I came on board late 2022. You were one of my first sort of proper PPIE roles, and I really enjoyed it. So you're part of my continuing story. Hopefully, some people will get that reference. But yeah, I mean, one of the things was I'm quite techie, so this is nice and techie for me. quite Spock, to be honest, techie trekkie. But the really good thing, and you know this anyway, I've told you many times, but you really did listen to my suggestions, and you did more than listen, you acted on them. And I could see that you'd acted on them. And that is the essence of public involvement and co-production. And you just get it. You really do. So that's why I was, more than honoured when you asked me to be the research partner, because I knew that I was I had somebody that I didn't really need to sort of explain all the time. Well, that's not actually co-production. This is co-production, or that's not actually co-design. This is what co-design looks like. You know it already, and so it makes the whole process so much easier. But yeah, it was just that first experience with Conquer. It just sort of was a real pleasure, and it sort of gave me the confidence that I could actually do this PPIE stuff, whatever that was back in the late 2022. I hadn't got a clue. It's like, oh, I'm just doing this now. I just go on to Zooms. You weren't even using Teams then. It was Zooms.
No.
And it was just, but it was just such a great experience. And I just found that Conquer was just like, this is really something that I really wanted to make happen. So now, we really are, me and the rest of the PPI lot and you, boss, we're making it happen. And basically, I just want to make a difference now. I've worked for the man for decades, and I never thought I was making a difference. In the last 3 years, I know I'm making a difference, and that's the difference between me now and me way back then. And you're part of that.
Made me a bit emotional, huh?
Oh, shut up. I'm always making Auntie Emma cry. She's on the top. She'll be in tears if she was.
So yeah, so as Tony was saying, so Tony is now our research partner. So going forward, we're working on this together. And so the next stage of what we're doing is this fellowship that I've been funded for the next sort of 3 years now, 2.5 years, just under. And so we're going to be looking at whether we can use Conquer as a tool to assess cognitive function for people with psychosis. So as I mentioned in my sort of first talk, we know that on average, people with psychosis have the most kind of profound cognitive impairments, that it is a really, truly unmet need for those people. And so while it's very much recognised that it would be beneficial to conduct cognitive assessments in services for people with psychosis, that is very rarely performed. And a lot of that is, to do with resources, is to do with the fact that the staff are not necessarily trained in the area of cognitive assessment, and those who are have very, very limited time. And so we really want to create something that they can use. And so once we'd kind of adapted Conquer, the next stage for us is really to start looking at whether it might be possible to use this and what we might need to do. So over the next sort of 2.5 years, we're going to be undertaking some research to support that design and development of Conquer. And so there's sort of 3 main things that we're looking to do. So the first is that we want to assess whether it's acceptable and usable for both sort of patients and people with lived experience and clinical staff. We also want to establish whether Conquer is giving consistent measurements of cognition across time, because that's really important if we want to show that it's a reliable measure that can be used in clinical services. And then the final thing that we're going to do in the sort of last year of the project is really using the results of the studies that we've run to be able to refine Conquer's design to maximize the engagement and maximize the likelihood that people will use it. And then we're going to be developing some protocols to test it and potentially sort of implement it in clinical services. So that's the kind of very brief overview of the project. And I think with that, we're sort of coming right on time into, well, into the Q&A session.
Fantastic. Thank you both. So yeah, as Amy said, it's time for the Q&A. So thank you to everyone who submitted a question in advance for our panel about cognition and mental health. We'll try and get through as many questions as we can in the time that we have, but please note that we're not able to provide personalised mental health advice. So if someone you know or you are in need of support, please contact a healthcare professional. Additionally, we may get round to some extra questions. So if you do think of something along the way, you can pop it in the Q&A box just at the top of your screen there. So I'll start with one of the questions that we had submitted. Is mental health and poor cognitive function also influenced by physical conditions?
Yes.
Tony, I think you've already sort of really kind of, addressed this. But do you want to say a bit more about your experiences?
Yeah, no, it 100% does. Physical health conditions do affect, well, they do affect mental health, but staying on topic, they definitely affect cognition. I mean, like, my biggest example is my long COVID. So everybody sees me out and about in the mornings. I'm like full of vim and vigor and pizzazz, and just generally fabulous. But you see me mid-afternoon and I'm just falling apart because my cognition starts to fall apart. My energy levels drop like a stone. I go to bed because I need to go to bed. I used to call it a bipolar nap, and that sort of worked. My bipolar plus long COVID nap, that doesn't usually work. You're catching me on a very good day because I can sort of use my spoons. Google that. That's a very interesting theory. My spoons, I can use my spoons, selectively on specific days like today. But normally, I'm gone in the evenings. All I want to do is watch a bit of Doctor Who and Star Trek and have a nice something to eat, and then I just crawl to bed. So it absolutely, physical health and mental health are totally tied together. And once again, shouting out from a long COVID fam, we need more research because that vagus nerve, that is really, really important to the function of a human being and even a Time Lord. So we need to know more about that vagus nerve because there's something gone seriously wrong with COVID-19 and the vagus nerve. They're not happy bedfellows, and we need to know why. Because if we can sort of answer some of those questions, we might be able to answer a lot of other questions that are connected to the vagus nerve. So yeah, but absolutely, all the physical health guys, they need to sort of talk to the mental health guys because that's how a body works. You're a full network. This is not separate to the rest of it. We know a lot about the rest of it. We don't know very much about this, and that's part of the problem.
100%, yeah.
Thanks, Tony. Anything to add there, Amy, or?
No, I think Tony's got it really covered. But one of the things that you said earlier, Tony, was around like some of the conditions that you talked about, like diabetes, things like hypertension. They are like so common for people who also suffer from mental health conditions.
Yeah.
And so, we know that it's kind of all working together, but it's so hard to get. First of all, you need like all the research teams to get together, as you said, but it's also sort of trying to sort of disentangle it all can be very, very tricky.
Yeah, it's we need to get back to holistic medicine, because guess what? That's how a human being and even a Time Lord works. It's all one system. It's not a bit of this, a bit of that, a bit of that, but the modern medicine, it likes to compartmentalize every bit of the body, and guess what? It doesn't really work.
Thanks both. We had another really interesting question about the relationship between cognitive decline and menopause. So is cognitive decline more rapid during the menopause?
So this is something that is not particularly well researched. So I'll be honest, it's not my area. Menopause is not my area of expertise. So I did do some reading earlier because I thought it was a fascinating question. So we know that obviously some women report changes in their cognitive function around the time of menopause. But the research for sort of observed changes is kind of more mixed, and there's lots of things around menopause that we know can like disrupt cognitive function. So things like, for example, sleep disruption, mood changes, all those things, hormone changes, they all can impact our cognition, but it's not really clear whether that's then sort of temporary and that gets better as you come out the other side of menopause, or whether that's then an ongoing issue. One of the things that has been looked at is in women with severe sort of mental health problems, so things like schizophrenia. They have looked at whether sort of menopause can worsen symptoms, and some studies have included cognitive impairment in that. And they have found that, around the time of menopause, cognitive impairment does seem to get worse for women, particularly with schizophrenia. And there's also been some studies in bipolar and depression showing that women are definitely reporting experiences of worsening memory around menopause. But I think we need a lot more research. We need a lot more sort of longer follow-up as well to really understand whether this is just sort of a temporary kind of situational thing, or whether it's something that becomes more prolonged.
Thanks,
Yeah,
Amy.
I mean, sorry, just to quickly add to that, I was brought up in a matriarchal family, and I do remember that my grands said that she was told that my mother's schizophrenia would improve when she went through the menopause. But then again, that was the 70s and 80s, and they had it was a completely different time. But I do agree with Amy. I'm very girl power, and we just need more research into women's health. Like, unfortunately, most of medical history has been for men, by men, to men, and we can't ignore 50% of the population of this planet. That's a very dangerous thing to do. So yeah, but I mean, maybe in the future, I'm using the railway that we can be part of the solution as well, because we've got plans with Conquer for a long-term follow-up, haven't we? So.
Thanks, Tony. And I should point out as well, we do collaborate with a reproductive mental health programme at Cardiff University. So I can pop the details in the chat about that matter. But we'll move on to the next question for now. So this is for both of you. Are there any strategies that people can apply to improve their cognition?
So shall I take this from an evidence base, like of what we
No,
know, and
I
then
can
maybe you
go
take it from
lived experience. Yeah, go on.
Yeah. Okay. So from a sort of evidence-based point, So cognitive remediation therapy is the main approach that we know seems to work. And that involves like completing these kind of cognitive exercises and then learning strategies and coping skills that will help you to manage your cognitive impairment. So the exercises are things like doing sort of pattern matching tasks to enhance your memory, sort of sorting tasks to help flexibility. And then the strategies that they're generally employed for that are things like kind of verbal rehearsal, so trying to like you kind of rehearse things to remember them, learning these kind of chunking techniques, so where you kind of chunk your information into shorter, smaller kind of bites that you can perhaps remember more easily, and then using kind of planning and time management strategies. And so that's been kind of shown to be effective by itself, but it's also very effective if you then pair that with a therapist who has specialist knowledge of cognition, and particularly if it's combined with like vocational rehabilitation, social skills training. The downside is that it's really intensive, and although it's recommended for adults with complex psychosis by NICE, it's generally not available on the NHS because there's the shortest of therapists, so shortage of kind of therapists, and there's a complete lack of funding, unfortunately, to be able to do it. So Tony, you don't know if you've got any strategies that you found help.
Yeah, so from the lived experience aspect, I've got a few personal strategies. One of the biggest ones is basically decluttering your life. I find that basically the bipolar was taking up so much bandwidth. I call it bandwidth, but it's just brain function. The bipolar was taking up so much of that trying to sort of live the old Tony's life as well, it just wasn't working. I just didn't have the energy. I just didn't have the brain capacity, So I mean, when you get a mental health diagnosis, a lot of parts of your life tend to fall away anyway. It's the nature of the beast. So I didn't really need to sort of declutter in that aspect, but I just find that it's not selfish, but self-care. Self-care is not selfish, and I think a lot of people with mental health issues are made to feel like that. The guilt that comes with mental health is tremendous, and it shouldn't be there, because at the end of the day, we're just trying to survive. And for quite a lot of time in the early days, it is about survival. I've had my moments. I've touched the void. And it is about survival. But now I'm sort of on a different part of my journey, and it is about sustaining everything that works and everything that's good, and having the time and space to do my new career in PPIE, but also have more time for me as well, because that's important. You have to learn to love yourself again, because your mental health condition takes that away. It makes you unlovable. You unlove yourself, and you've got to relearn to love yourself, and that really takes time. And you need to find, the two people that I found a few years ago. My Brian, who's my psychotherapist, and my Delith, who's my what I call on the ground support worker in Bangor. And I tell them all the time. And those two people definitely saved my life. But you've got to find the right therapist. And therapy is not an 8-week, 6-week event. I've been with my brain for 10 years now. And, you know, the first 3 years, we're just basically saying hello to each other, because you've got to build up trust with your therapist. And that's a two-way street. So, yeah, I mean, it's a journey, and once again, like I said about cognition, do not compare and contrast yourself with anybody else, because your journey is your journey. Your life is your life, you know, and you live your life, because guess what? Everybody else is taken.
Thanks, folks. Some really interesting insights there from both of you. We're just over time, but I wondered if we had time for just one more question before we go. So one of the questions we had was about medication. So are memory issues a direct result of negative mental health, or the medications used to treat poor mental health?
A bit of both, really. I think so. The actual evidence for how medications like affect your cognitive function is quite mixed. Part of that being because some of the trials are conducted by, you know, the pharmaceutical companies themselves, and others being because it's quite a difficult area to kind of disentangle. So there's sort of evidence that some medications might make cognitive function worse, whether directly or because of the kind of side effects that people have from them, so things like sedation. There's also some evidence that some of the newer medications, like some of the newer antipsychotics, newish, might slightly improve cognitive function, at least partly by sort of alleviating some of your other symptoms. But I think the trickiest thing about this area is like disentangling the effects of medication and symptoms. So the ways that we've always typically measured medication is like we look at the type of medication someone's taken, the dose, the length of time that they've taken, but that's related to the symptoms you have, the severity of your symptoms, the duration that you've had your symptoms. And so it's very, very hard to disentangle the two. But we have got so one of our PhD students, Siobhan Locke, is doing some really interesting work looking at like other ways that we might be able to look at medication. So she's particularly interested in genetics, and how our genetics might predict how we kind of metabolize certain medications. So she's been looking at sort of antipsychotics, and she found that people who sort of metabolize so clozapine, which is a particular type of antipsychotic, faster, seem to have slightly better cognitive function. And so one of the things they kind of posited is maybe that's because it's sort of not the drug's not staying in your system as long. But yeah, we're a long way away, I think, from really being able to truly sort of disentangle the two. The one thing that we do know is that when we look at people before they go on medication, there are studies looking at people who haven't received any medication yet. The cognitive impairments are already there for a lot of people. So it's not sort of the case that, you know, they sort of the medication is sort of solely causing cognitive impairments, but we still don't know a lot about how much they might kind of make them better or worse, really.
Thanks,
Yeah.
Lee. Sorry, Tony, I've interrupted you then.
No, sorry. So once again, we're a double act. So from the lived experience aspect, so I've got two lived experiences. I've got the lived experience with my mother and with myself. So with my mother, this was 70s and 80s. Back then, mental health treatment was basically sedation. But with my mother, she had schizophrenia and grand mal fits. I mean, and I've seen my mother at her worst, and you know, it was quite pitiful but frightening at the same time, and especially as a child. But so she needed that sedation, but but as time went on, you know, it does impair the cognition. I mean, you know, before she became really ill, she was a punch card operator, and if you have any concept of that, that was like cutting edge computer operator back in the early 70s, and she would have had a marvelous career if her mental health had been different. But yeah, I mean, you know, things changed later in her life where they did have a look at a medication, and she was able to sort of have a much better quality of life and live her life. So there's that, and then from my personal experience, I started with the classic antidepressants, and like for bipolar, well, it just solves one part of the equation, and it does nothing for the mania. So I wasn't depressed, but boy oh boy was my mania having a great time, and it was also not doing very much from a bank account. As I used to say, well, like when I was depressed, when I was manic, I broke my bank manager's house, and when I was depressed, I broke my heart. So we got to the stage, and my personal journey has been all about the locums. So shout out to the locums, because you're doing a fabulous job, because they want to make a difference, and they do make a difference. So my the locum that really helped with the medication, he was a registrar up at Ysbyty Gwynedd. Hello, Betsy. And he basically convinced me to ditch the antidepressants and go on to a mood stabilizer. And I was, for 15 years, I said, no way am I going to mood stabilizer, because I'll be living in a box. Because like a mood stabilizer to me was like, this is how you live, and this is how you're not yourself. You're just this thing that's within the parameters of the mood stabilizer. Anyway, he convinced me, and I'm so glad he did, because it really has been quite transformational. You know, I am much better on the mood stabilizer. I'm still me. I'm still able to sort of be all singing, all dancing. And I do, you know, have the highs and lows, but that's human. Time Lord, whatever you want to call it. But it's not, I'm not getting those extremes, and that's the important bit, because it's very difficult living with the extremes. So the medication, the drugs weren't working, but now they definitely are.
Oh, thanks, Tony.
Thanks both. Yeah, so unfortunately, that's all we've got time for today. Thank you, Tony and Amy, for your participation, and thank you, everybody, for attending. If you'd like a little bit of a summary about Conquer, I've put the address in the Q&A box there. It's conquer.wales/about. It also contains some information about the National Centre for Mental Health and the Centre for Neuropsychiatric Genetics and Genomics. Is there anything else that you'd like to leave our attendees with today, Amy and Tony? Or
I was just going to say thank you for coming, particularly as the weather is so lovely. I can see out my window. So thank you so much for coming. And you know, I hope you really enjoyed it, and that you found it useful. People are welcomed, you know, to contact me if there is anything that they're particularly interested in, or they'd like more information. Then you can Google my name and Cardiff University, and you will find me.
Yeah, and I'm on LinkedIn, so you know, anybody wants to link in with me, then just that's great. So I'm under Anthony Cope, not Tony Cope. So just so that people are aware, it's like, where is this fool? I can't find it. So it's Anthony Cope on LinkedIn. But yeah, once again, just to reiterate what Amy just said, it's like thanks for you know, it's just great to sort of and thanks for all the thanks. But it's just great to have so many people interested in what we're doing. You know, like we're just a little research group in Cardiff University, and you know, like but we just want to make a difference, and hopefully we are.
Fab. Thanks both, and thank you everybody for coming. Wish you a pleasant evening. Bye.
Bye.